antibiotic.
Okay.
This is going to be the antibiotic ladder. It's going to show you what to do what antibiotics to do when. So we're going to start here. So in the beginning of antibiotics, penicillin was the first antibiotic which was found. It covered both gram positives and gram negatives equally. But we don't use it anymore. The only time we use penicillin is for syphilis and for whatever else, but we don't use that anymore. So moving gram positive, the main thing we would scan about is Staph aureus. So for Staph aureus, it's either methicillin resistant or methicillin sensitive. Methicillin resistant, sensitive Staph aureus causes skin infections, your pneumonias and stuff. So for those patients, start off with oxacillin, napacillin if they are methicillin sensitive. Moving one step ahead, if you have methicillin resistant Staph aureus, then it's Vanco. Linezolid only covers methicillin MRSA. You don't use linezolid to cover all of gram positive. It's only sensitive to MRSA. Vanco is only sensitive to MRSA. So if you suspect MRSA, give Vanco or Lins. Don't do
Vanco or Lins.
Vanco or Lins. Vanco first, then Lins. Lins because of this thing. So that's the gram positive aspect of it. Now moving on to the gram negative aspect of it. You start off with ampicillin and amoxicillin. Obviously, that covers all your gram negatives, E. coli, all that nonsense. And then we developed beta-lactam, which covers a bit, it got you some coverage. Gave you beta-lactams, where it covers gram negatives and gram positive, but it did not touch MRSA, nor did it touch MSSA. So for those bacteria, so for those things, okay, if you're suspecting MRSA, don't give augmentin, don't give this. This covers augmentin, when you're looking at giving augmentin, you want a broad spectrum coverage of gram negatives and gram positives. So when you have a UTI, non-complicated UTI, things like that, when you want to cover both, you give this or some sort of skin infection. If you're suspecting MRSA, don't give augmentin. Moving one step ahead, we have Pseudomonas. We wanted Pseudomonas coverage. So for that, we developed Piperacillin. Piperacillin only covered Pseudomonas, which is completely gram negative. So then we're like, no, we want something a bit more extended coverage. So we give Tazobac. Tazobac again covers a bit of the gram positives, not fully. So if you're suspecting MRSA, don't give Tazac. It does not cover. It's only for Pseudomonas. And the last step after that was carbapenem. So you see how it went from penicillins to augmentin, this thing, methicillin, MRSA. Then we added beta-lactams. Then we went to this thing, and lastly carbapenems for gram negatives. So this has to be our last step in our antibiotic ladder for gram negative bacteria. Now moving on, we have the cephalosporin. So the cephalosporin, there are 4 cephalosporin classes broadly. And right in the middle in number 3 is where you have gram positive and gram negative. So number 1 and 2 cover gram positive, 3 and 4 cover gram negative. So you can see this is how the graph looks. So from positive is like this, it comes like this and comes down. And negatives, it starts from here and comes down. It's like my alarm is ringing because it's time for me to leave. But anyway, so gram positive. So if you're suspecting a gram positive coverage, go for 1 and 2. So obviously when you have orthopedic infections, when you have bone infections, when you have trauma, you're thinking of skin commensals, just thinking of, so always go for cefazolin, cefalexin. These are cefalexin. These are all indicated for soft skin tissue. If you can give gram positive coverage, give 1 and 2. Moving on to number 4, it's only indicated for Pseudomonas. That's completely gram negative. So you have cefepime, cefep. So when you have some sort of sepsis with Pseudomonas, you give cefepime. Monoseph, ceftriaxone, cefixime is gram. So if you want to start empirically and you want to cover both sides, you don't know what it is, but you want to cover both sides, you give ceftriaxone. And obviously ceftriaxone enters enters the CNS. So if suspecting meningitis, you can give that. So this is the bare minimum of the antibiotic ladder with cephalosporin. Now moving on to fluoroquinolones. In fluoroquinolones, imagine it's called the fluoroquinolone diamond. Okay. Number 1, 2, 3. If you play baseball, you move like this, right? You come back here all the way to number 4. Number 1 and number 2 cover gram negatives. So number 2 covers both gram negatives and gram positives. So if you're suspecting a gram negative coverage, UTIs, etc., go for ciprofloxacin. There's no need to give moxifloxacin and levofloxacin. Number 2 covers a bit of gram positives and a bit of gram negatives. So levofloxacin is a very good respiratory fluoroquinolone. You're suspecting pneumonia, suspecting all of those things, you do levofloxacin. Lastly, moxifloxacin covers only gram positives. So again, pneumonias, soft insulin, you can give moxifloxacin. But never start with moxi immediately, never start with levo. These drugs are usually indicated, other than ciprofloxacin, levofloxacin and moxifloxacin are usually indicated for infections which don't respond to cephalosporins. So if you want an added gut punch, go for these two. So that's your fluoroquinolone done. Now moving on to anaerobic infections. Anaerobic infections are infections which we know we cover a lot, especially in trauma. The main stay of rule is, imagine a guy and you put a line. Anything above the gut. That means skin infections, aspiration pneumonia, anything above the gut, give clindamycin. Anything above the gut, give clindamycin for anaerobic coverage. Anything below the gut, give metronidazole. Metronidazole will not help above the gut. Clindamycin will not help below the gut. And if the patient is septic and you want to hit hard and fast, give Tazac, because Tazac covers gram negatives, a bit of the gram positive, and all anaerobic. There is no indication of giving Tazac with Metrogyl. It's like saying giving a bottle of water and a cup of water for fish. Both are water, cups of water, both of them. If you're giving Tazac, it covers anaerobic, it covers the. So all septic patients, if you're covering anaerobic, give Tazac. Otherwise, clindamycin for above the gut, Metrogyl below the gut. Lastly, empiric antibiotics. So for empiric antibiotics, this is what we normally deal with ED. If you have a septic patient, what antibiotics to give them? If you don't know what it is, if you don't know what, by the way, sepsis, if you all know what is, I mean, I won't go into sepsis, like definition of sepsis, but just to know that if you're having an unknown sepsis where you have a patient who's come in, you don't know what to do, patient sick, Q-SOFA score is 3, he's going into septic shock, unknown set, give meropenem or vanco, no problem. Meropenem first line because it covers mostly gram negative, and gram negatives are the ones which cause a lot. If you suspect vanco, if you suspect MRSA, give vanco, no problem. Same thing with healthcare associated unknown sepsis. Meropenem is a good drug of choice, even with nutrition. So that's your unknown sepsis. Moving on to pneumonia. Pneumonia, you have two types of pneumonia. You have community acquired pneumonia and hospital acquired pneumonia. Community acquired pneumonias usually have non-resistant bacteria, non-antibiotic resistant bacteria, which, so if you have mild pneumonia, patient who's come in, who's coughing in front of you and you give an antibiotic, Azee is a good choice, Doxy is a good choice. Okay, those are for mild. Moderate to severe community acquired pneumonia. Monoseph is good, Azee is good, Doxy is good. So just give me another mark. And if it's hospital acquired pneumonia, that means patients come here, he suddenly is having pneumonia, that means these bacteria are resistant. So you have to give something which is resistant. So if it's hospital acquired pneumonia and it's this thing, you can give cephazolin sublactam. Why? Because when you're giving cephalizum and sublactam, cephazolin is a grade 2, but you're giving sublactam which extends the spectrum to gram negatives also. So you're getting both gram positive and gram negative. So that means it is a good coverage. So cephazolin and sublactam, which by the way, it is our consultant's favorite.
Patients come with moderate community acquired pneumonia requiring hospital admission.
Yeah.
And if I start Magnix foot?
Magnix foot will work because now you're covering both gram positives and gram negatives together. You're not covering the dead ones, like the dangerous ones, but you're covering everything. So it's a good empiric antibiotic. So Magnix foot, cephalizum sublactam is a good one. But if you have a hospital-acquired pneumonia, which is severe, which is a patient who's been here, you have to suspect two things: MRSA or Pseudomonas. Pseudomonas and MRSA are very common in our ICUs, which infect, so we have to. So either you can give cefepime or you can give vancomycin. And if you want, if the patient's aspirated, remember, anything above the gut, give clindamycin. Anything below the gut, give Metrogyl. So if you have aspiration pneumonia with hospital-acquired pneumonia, you can either give cefepime or vancomycin. So that's for severe hospital-acquired pneumonia. Along with that, if you have risk factors for MRSA, that means diabetes, immunocompromised, previous MRSA infections, those are all risks. So if you have a patient who has MRSA infection, MRSA UTI or MRSA skin infection, who's come again with an infection, who's diabetic, immunocompromised, don't assume that it's not going to be something else. It's always 99.9% it's going to be MRSA, so treat for MRSA. Either with Vanco or this thing. If not, give cefepime. And if it's affecting gram negatives, you have your Tazac or lastly carbapenems, because you don't have time. For all mild abdominal infections, you can give Monoseph and Metrogyl. Why? Monoseph covers gram positives and gram negatives to some extent. Metrogyl is for anaerobes. Anything below the gut you can give. Monoseph, Metrogyl for all abdominal infections. Severe abdominal infections, give meropenem, atropine. Why? Because the bacteria which cover the abdomen, which cause abdominal sepsis, is usually gram negative. So hit hard, hit fast with gram negatives, either meropenem, atropine, whatever. That's your abdominal infection. For meningitis, which is, we need a certain coverage which penetrates the CNS. You can either start with ceftriaxone, vancomycin, cefepime. All three of them cover the meningitis. If it's a patient who's come in for the first time with this thing, hospital required with suspected meningitis, give ceftriaxone. If he's post-op, if he's done this thing, if he has a incision over here, has been admitted, most likely there's the bacteria from the hospital has gone in. Give either Vanco or ceftriaxone. Why? Because it's ceftriaxone. Lastly, for skin infections, well, we started over here. If it's mild skin infections, MRSA, give oxycillin, ampicillin. No problem. If it's MRSA, give Vancomycin, and if you have abscess formation or if you're suspecting toxin formation, give clindamycin, which eliminates the toxin and helps in abscess formation. And that is the very brief of antibiotics and what to do.